Hey class, so today we are lecturing over test 3. So we're going over the bowel and bladder chapter and vital sign chapter. And I'm going to get through as much as I can for you guys today, and then there's probably going to be a part 2. So for the first part of this lecture, bowel and bladder. So when we are talking about geriatric patients, they're usually classified as being continent or incontinent. Incontinent, they're unable to control their bladder. In bowels, continent, they are. We talk a lot about catheters in this chapter, and the term catheter we need to understand is any tube that that can drain or inject fluid from the body. So when we are discussing catheters in class, we're not talking about IVs or surgical drains that can also be classified as catheters, but we're talking about either a Foley catheter or a straight catheter. Foley catheters are what we work on in class. That's when we practice with patients that have that indwelling Foley catheter. The balloon is blown up in the bladder, and it stays until we need to remove it or change it. A straight catheter is for our patients that either they have not been charted, that they have voided within a certain amount of time, usually between 8 to 12 hours, just depending on your facility. And that would, or when we need to get a urine sample. So that would be, we're going to insert the catheter, drain the urine from the catheter, and then pull it right back out, either to just empty the bladder or to collect a sample. So when we are talking about catheters, and you guys know this from doing skills in class, when we're talking about Foley catheters, we have to be careful and ensure that we're cleaning them properly, because they're a major risk for UTI. So when I am doing catheter care, I'm ensuring, first of all, that that catheter never, the bag never goes above the level of the bladder. Also that there are no kinks, and that that catheter is able to drain properly. And then we're making sure that we're emptying those catheters and recording how much urine is in those bags every 12 or 8 hours, depending on your shift. There are several things that we use for our continent patients, either bedpans, and you guys have worked on bedpans. Urinals are what we use a lot for male patients, and when we have a male patient that is using a urinal, so just essentially a pee jug, we need to make sure that that is close, that he can reach it on his own, and then we need to make sure that we're emptying those as soon as possible, as quickly as we see them full. The other thing that we use for males is a either a condom catheter or a Texas catheter, and those essentially, just like they sound, they are a external catheter, so they look just like a condom. We're going to put them on our patient, and then usually they're used throughout the night for continent men, usually with prostate issues. When a male has prostate issues, they often have to urinate every hour, but they're only getting a little bit out. So to prevent those patients from having to get up and down all night long to urinate, we can put the condom catheter on. It drains into a bag just like a indwelling catheter, and then we empty it and remove that in the morning. A couple terms that I need you guys to know. Remember, dis is always difficult, and then urea is going to be our suffix for urine. So dysuria is going to be difficult urination. Hema being blood, so hematuria would be blood in the urine. And obviously anytime we have blood in the urine, that is something that needs reported immediately. So anytime we have a red colored urine, when we are charting urine and looking at emptying our patients' catheter bags and things, or urinals and things like that, we have to make sure that the urine is the correct color and has the correct odor. So by odor, I mean obviously we're not sniffing the urine, but normal urine, if you are drinking enough water, if you are hydrated, has a faint smell to it. when our patients are not drinking any water. So when you drink Red Bull and coffee all day, your urine is going to have a much stronger smell. And on the opposite end of that, when you have been super healthy or outside working out or whatever you've been doing, and you've drank an abundance of water all day, your urine has zero smell. Same with color. When we drink Red Bull and Mountain Dew all day and no water, our urine is going to be a dark concentrated color. And then on the opposite end of that, if you drank, 4 Yetis full of water today, your urine is going to have almost no color and just be clear. So we want our patients in the healthy middle, where they have a faint urine smell and just a straw pale yellow color. More pale yellow than straw. Straw would be a little bit darker. Remember, anytime we're talking about incontinence, anytime we're talking about anything related to our geriatric patients, that our 2 main concerns are going to be skin and falls. So, of course, incontinence brings a risk for falls, whether they're continent or incontinent, any type of bladder issue. If they are continent, then most likely a geriatric patient is going to not have the ability to hold it as long as we would. So when they have to go, they have to go. So that puts our patients at risk when they hit that call light, if I don't answer it fast enough, that they're going to try to get up and go themselves. Also, if I have an incontinent patient, just because they do not have that urge or the feeling that they need to go, they do have the feeling that now they're wet. So they didn't know that they needed to urinate, but now their brief is wet. And the likelihood of them trying to get up and change that themselves puts them at risk for fall. Skin is a major issue. We need to be changing our patients every 2 hours. Remember, that's our golden number. And even with every 2 hours, if I have a patient that is dehydrated and has that dark, strong urine, and that's sitting on them for even an hour, that's going to lead to some skin irritation and definitely to some skin issues, skin breakdown. When we are, so incontinence is generally not reversible, but it can be. So in the instance of a patient who has had a stroke or an accident, some kind of trauma, and they have become incontinent, that can be reversible. Now, if I've got a dementia Alzheimer's patient that is incontinent due to that disease, we're not going to reverse that. If it is reversible, we do what is called bladder training. We can also do bowel training. So when I'm doing bladder training, if I have an incontinent patient with no catheter, what I'm going to do, as opposed to checking their brief or offering to toilet them every 2 hours, I'm going to physically assist them to the bathroom, regardless if they have the urge or not, every 2 hours, and sit them on the toilet. And this kind of just will act on gravity. So, and then just the sensation. So just sitting on the toilet sometimes will give them the sensation and help them go to the bathroom. So that's every 2 hours, regardless if they have the urge, regardless if they're already, if their brief is already wet, I'm still going to get them up. Same with bowel training, whether they have the urge, whether they've already went, every 2 hours, we're getting up and we're sitting on the toilet. We can do things like, provide privacy, but we can also turn on the water, and sometimes the sound of that will help them to go. And then you can also, where you pour warm water over their peri area, and that can help generate the sensation so they can go. If I have a patient with a catheter, an indwelling Foley catheter, I can still do bladder training. So the way that works is I'm going to clamp that catheter for a period of time and then unclamp it every 2 hours. So generally I may be clamping that catheter, and it just depends on your order, for an hour and a half, and then for 30 minutes I will unclamp it. So this gets the bladder used to filling up and then releasing, as opposed to just constantly releasing as soon as the urine is produced. So the bladder gets full, the catheter's clamped, I go in and unclamp that catheter, and then the urine can flow. So that's bowel training or bladder training, and that's done every 2 hours to reverse incontinence. So incontinence can be reversible. For bowel, there's several things to go over. Constipation is a huge issue in our geriatric patients. So we have 4 different things that can cause constipation, and 4 things that you guys as aides can help with and reverse without ever having to talk to your nurse. So the first cause of constipation is going to be diet. So lack of fiber in their diet, just not eating healthy, not eating much at all due to not liking the meals provided. So diet is number 1. Number 2 is going to be dehydration. If I have a patient that is dehydrated, that is not drinking enough water, they're going to become constipated. Number 3 is immobility. So we've got a patient that is maybe they're an assisted 2, they're not getting up very often. Maybe they're bedridden and they're non-weight bearing, so they're not getting up at all, and they're in bed all day. So that immobility can lead to constipation. And then number 4 is pain medication. So and there's not too much we can do about that. But so when you think you've got a patient that is freshly in the nursing home from hip surgery, they're taking pain medication every 4 hours, they're not getting up and walking because they've just had that surgery, and then their diet and their hydration is poor because they're just laying in bed all day, they're not at home, they're not eating and drinking like they're used to. So as aides, as good aides, there are several things we can do to combat each one of these to prevent our patient from ending up on a Bowel list when they would have to start taking medication to be able to go. So generally most facilities, if your patient has went 3 days without a bowel movement, they're going to place them on the Bowel list. And that's when we're going to start doing Colace, suppositories, enemas to help them go. If you have a patient that is 2.5 days in with no bowel movement, it is your responsibility to help that patient and to be proactive before we have to start giving them medication. So if your patient is dehydrated, then we need to be pushing fluids. So by pushing fluids, I mean every time I walk into the room, and I need to be doing it more than every 2 hours, I need to be handing my patient their water and saying, take a drink for me, take a drink for me. Not just, would you like something to drink? I just need to put the drink in their hand and push those fluids every 2 hours. If I have a patient with poor diet and they are constipated due to lack of fiber, I can provide them with high fiber snacks. So most hospitals have those like Fiber One packets or whatever they are, just snacks that are high in fiber. I can be providing them with fruits, ordering extra fruits and vegetables on their trays, and things like that to help them get more fiber. If it is due to a lack of immobility, then I need to be getting that patient up. Even if all I can do is walk them around the room one time or walk them around the hallway, even if the most I can do is take them from bed to wheelchair, I want to move them somehow. So if my patient has not had a bowel movement without me ever talking to the nurse, these are things that I need to do to make sure that my patient can go before we have to start giving them medication. Some symptoms of constipation. Obviously, you've not had a bowel movement, and your patient can tell you. But also, when our patients are constipated, they're going to have stomach distension, so their stomachs become hard. They get a feeling of fullness, so they're unable to eat because they feel so full. They can have feelings of abdominal discomfort, so their stomachs are distended, their stomachs are hurting. They feel symptoms like indigestion and heartburn from being so full. And really it's just miserable for them. So if we have a patient that's complaining of constipation, even if they're not on day 2.5, these are things that we can be doing to help them just so they're not feeling so miserable. On the opposite end of that, of having a patient that is constipated, is diarrhea. So if I have a patient with diarrhea, then I'm going to be concerned with the two things that we're always concerned with, not dehydration, but skin and falls. So if I have a patient with diarrhea, even if they're continent, if they have diarrhea, they're not going to have time to put on their call light and wait 20 minutes for me to come answer it and take them to the bathroom. So they're absolutely going to try to get up and go without me. So I have to be really vigilant that I am getting to them in time. And then their skin. If I have an incontinent patient with diarrhea, I do not want that stool sitting on their skin for any amount of time, because it's quickly going to cause breakdown and cause skin issues. When I have a patient with diarrhea, I'm obviously going to be concerned about dehydration and then becoming dehydrated. So I need to be pushing fluids on that patient and keeping a very close eye on them to make sure that they're getting to the bathroom and that they're staying clean. When we have a patient with diarrhea, most of the time we are going to assume that it's some type of viral infection, that they are sick somehow. But of course, that's not always the case. Sometimes our patients can have that just from something they've ate or anything like that. The other thing when it comes to bowels, very close to constipation, but is a fecal impaction. So when my patient has a fecal impaction, that is essentially a hard ball of stool that is blocking their rectum, so they're unable to pass any stool. When I have a patient with fecal impaction, they're going to have the same symptoms of a patient with constipation. So that feeling of fullness, the distended stomach, abdominal discomfort. The difference here is going to be when I have a patient with constipation, they're not passing anything, as opposed to if I have a patient with fecal impaction, because I have that hard ball of stool blocking their rectum, they're going to be having watery stools. So basically seepage going past the fecal impaction, going past that hard ball of stool. So they're going to have watery stools kind of seeping out until we can get that impaction taken care of and removed. Okay, so that is all for bowel and bladder. That's the most important things that I wanted to discuss with you guys. So I'm going to end this, and then I'm going to add another one going over vital signs for you.